Let us see. Because the slide gets stuck, I need to follow in this pattern only, yeah? So somehow it doesn't seem to work very well for me.
This is how it is looking on the NMC, and I just wanted to show you on my phone.
Okay.
I'm also checking how it's looking.
Thank you.
Okay.
Now, we have talked fairly extensively about selection of patients in the initial portion of the talk. Now, we need to mention about how do you select the antigens. So, we know that after the skin test is interpreted, don't get too excited, sit down with the patient and go through this summary conference and try to get the clinically relevant antigens. Now, ground rule is the less number of antigens that you get, the more potent the vaccine will be, because you also reducing the dilutional factor. And generally, as I mentioned before, we try to be very conservative with molds, not to mix it with pollens due to a couple of different reasons. And generally, we don't go exceed more than 3 antigens generally, but in the US, we do this. We have a lot of polysensitized patients. Sometimes they use 8 to 10 antigens per set. So let me see, I need to talk a little bit about the nomenclature, a few things for the group. Now, if you look at, we keep on using this DERP1, DERP2, FELD1 like that, and that is how we are addressing the allergenic portion, the epitopes of these different allergens. And how did this happen? Actually, this boat ride happened where these 3 famous allergists, Dr. Marsh, Lowenstein, and Platt-Mills, during one of these major meetings in Europe, they went on a boat ride and they started talking about how to do this characterization, how to do this nomenclature, and came up with these very good recommendations where they would take the genus and use the first 3 letters. If you take dermatophagoids, Pteronoecius, dermatophagoids is the genus, and you use the DER, and then you use the first letter of the species. Pteronoecius is the species, use the P, and then you give a numeral, Roman numeral. So that is how DERP1 came into existence. DERP1, DERP2, like that. You have DERP17, like that. It keeps on going. Same thing with Felis domesticus, cat, FELD1. Canis familiaris is CAN F1, Alternaria alternata, ALTA1, like that. So this nomenclature is the first 3 letters are representing the genus, then the species, then the Roman numeral. Then we have this, we use the term effective dose. We use the term major allergen. So what does that mean? Effective dose is the amount of the effective dose is the highest dose that we use of the major antigen. What is a major antigen? If you go ahead and skin test or do immunocap on a group of people, if more than 50% of those persons are sensitized to that particular antigen, it is called major antigen. It is not the intensity of the reaction, it is how broadly it is spread in the allergic population. So that is what a major antigen. The major antigen in India is dust mite. We know that 82% of people are sensitized. Allergic patients or sensitized patients are sensitized to dust mite. So dust mite is a major allergen in India. Is cat is a major antigen in India? May not be. It could be only 30% of people could be sensitive. It's not a major antigen. But dust mite is a major antigen in India. Just like that, and the highest dose that you give in immunotherapy of that particular major antigen is called effective dose. That is called maintenance dose. So it is a quantity of the major allergen that is delivered is called the maintenance dose, and that is called effective dose. So when I say I want to give 20 micrograms of dust mite per month, that is an effective dose. That is therapeutically effective dose. That is, whenever I'm talking about immunotherapy here, when I'm talking about the dosage, it is based upon subcutaneous immunotherapy, not sublingual. So subcutaneous immunotherapy, maintenance dose is given every 2 weeks, and the amount of antigen we deliver with subcutaneous immunotherapy, which seems to be therapeutically effective, is 10 micrograms per injection. And these maintenance injections are given twice a month, so that comes to 20. So the quantity of the major allergen delivered is what we call as a maintenance dose, and that is the effective dose. So now you know what is a major allergen, and you know the concentration, and now we know how much is this product that is coming from this pharma company or the antigen company, how much major allergen is there. And then I also know now what is the therapeutic range where it is effective, and this will help us to write what we call as an evidence-based formulation. So this looks a little bit could be confusing. Several slides in this presentation could be a little bit confusing, but don't worry, we'll just look at it and go forward, because we are going to probably repeat it later on again and probably look at it much more deeply in refresher courses. But just look at that the major allergen required in this particular bottle to be made up, you need at least Timothy of 20 micrograms per dose, and ragweed so much, dust mite so much. And this is just telling you how that serum is made up, but I'll tell you a little bit more later. Now, we need to talk a little bit about potency. The reason why we are mentioning it, there are too many units of expression in the field of allergy, which is terribly confusing. So weight per volume, which basically is how much of that vaccine is there per so much of volume. That is all. It is not a expression of potency. PNU again is a protein nitrogen units per ml, is not an expression of potency. But BAU and AU are the two consistent units that are indicative of potency. BAU is a biological allergy unit, and AU is the allergy unit. You need to use only those two units to express the potency, not PNUs and not weight per volume. Those are all empirically used. Biological allergy unit is based upon it is done in vivo by titration technique intradermally. AU is done in the factory. In more on a commercial, in the machinery or whatever they use. So you have what we call as a cross allergenicity among pollen. This is something we need to also look at when you are writing up these vaccines, because say for example, patient comes to you highly sensitized to many grass pollens, and he's sensitized, has a good history and good match with his history, and then you say, I want to treat you with the grass pollens. Now, how do I select which grass pollen? There are 6 of them. Now, you don't have to mix all of those into the vaccine. We just know one grass pollen, which is cynodon, which is the Bermuda grass, is antigenically different from any other grass. All the other grasses cross-react with each other. So you can just take one of the other one, like Timothy grass, and mix it with the Bermuda grass, and that takes care of all the grasses. So you need to be aware of this cross-allergenicity, which is existent, especially among grasses. Cross-allergenicity is not a factor a whole lot with trees. When you're treating tree pollens, each tree is different, and they don't cross-react. And trees are the only ones that change from area to area. Trees are different in Kashmir compared to Kerala, but the grass is the same. Trees are different from different areas, so you need to take care of the trees when you go to different areas more than the grasses, because they are very similar. So cross-allergenicity is something you need to be aware. Even there is definite cross-allergenicity between dermatophaga derp1 and derf1. Even if you treat one of them, it is effective. And now we need to know how to mix. There is a substance called protease. Protease is present in all these different products, in these different vaccines, in these antigens. Is an integral part of the vaccine or integral part of the allergen, and there is what we call as a high protease, low protease. Now, if you look at the pollens, they are all low protease. They don't have much protease. Cat and dog dander has no low protease. Dust mite has low protease. This is the imported USA one. I don't know about the Indian one. But molds are all high in protease. What is the significance here? When you mix high protease with low protease, when you are mixing to make up a prescription, or making up a vaccine for treatment, the high protease antigen will eat up the ones that has got the low protease. It will just denature the whole thing. So it is very important for you not to mix high protease with low protease, including cockroaches high protease, molds are high protease. But you can mix low protease with low protease. So that means you can mix dust mite, US made, with pollens. No problem. You can mix that because all pollens are low protease. But you cannot mix with molds because it's high protease. You can do two different molds as long as, because both are high proteases. Sometimes high protease can auto-digest itself, but it is not that significant compared to when you mix with low protease. And this slide is a little complicated. Basically, it tells you that you cannot do the mixing and this denature can occur. Now, whenever possible, standardized extract should be used. What is standardization? There's nothing like, just because it is standardized doesn't mean it is perfectly fine, or the other way is true. Just because it is not standardized doesn't mean that antigen is bad. Standardization means consistency, each batch is consistent to the next one. And that is what standardization is. And that is something that we need to be aware of, because in the pharmaceutical industry, standardization is a basic factor. When you are using antibiotics or any of the medications that we use, on the label it will say 250 milligrams or 500 milligrams per tablet, whatever, and when you measure it, that's what it is. But do we have such a thing with immunotherapy treatment programs? Do we have such things for pollen extracts, dust mite extracts? Answer, we don't have any standardized material in India, but even in the US, where if there are 75 total antigens available, only 20 of them are standardized. But does it mean other 55 are bad? Not really. They are quite potent. If you measure the BAU units or AAU units, they are good, but they may not be standardized. That means their potency can vary from batch to batch. How to write a prescription for allergen immunotherapy. Now, this is a thing that can take a lot of practice. It can vary between doctors. It can take time for you to feel totally comfortable. It is very common for people to make mistakes. That is why we say, write a prescription with a mentor. Go ahead and write it, then send it to one of us. We will take a look at it and tell you what could be the issue. But when you send it, just don't send your prescription. We want you to write a history, write the skin test results, find out what is the clinically relevant, why do you think it's clinically relevant, and then write a prescription, then you send it to us. So it is like another sort of a small assignment for you, where it will tell us whether your thinking process makes sense and whether you are selecting the right antigen for treatment and how you are going to treat it and what your prescription would be. And then we can go through this modification if necessary. And try to work on scenarios, make up a scenario or pick up a scenario and just write it up. Or you can use scenarios from your existing patients. And do not hesitate because you're going to make mistakes, because you will. And we did the same thing. We did a lot of mistakes and now we are feeling a lot more comfortable. Now let's look at this. 16-year-old male, progressively worsening rhinitis, nighttime cough, 6 months duration. And pale boggy nasal mucous membrane, reversibility shown. So he definitely has some atopic disease, has some extension into the lower airways, has asthma too. So both upper and lower airway. And when you look at the skin test, if you look at it, I will interpret for you because it will take time otherwise. First thing I want to look at it is the controls. Whenever I want to interpret skin test, I don't look at big reactions. I only first look at controls. I look at the saline control first and see it's 2 millimeters by 2 millimeters, which is acceptable. Yesterday we went through the skin testing. That means baseline reactivity of the skin is acceptable. And then I look at histamine, which is a positive control, and that is acceptable too. Anything 4 by 4 is acceptable. That means there is no interfering agents, no antihistamines floating there. Then I start looking at the other specific antigens. I look at DP, dermatophagocytic pteronosis, looks big, 12 by 10 with pseudopod erythema, which seems to be a significant reaction, strongly positive. DF 8 by 10 also is strong, but DP is stronger. Cockroach is positive, cyanodon is positive, Timothy grass is positive, everything is positive, because a positive reaction is 3 millimeters above saline control. Saline control is here is 2 by 2. A positive reaction should be minimum 5 by 5. And you look at it, all of these things are positive. So what is clinically relevant here? So I had to sit down, go through the history, which I did, and then I found the culprit antigens could be dust mite, prosopis, cyanodon, could be cat, cockroach, and alternaria. Then I took further history and find that the 3 things I would like to really concentrate are dust mite, Timothy grass, and the Bermuda grass. Grasses and dust mite are the ones I really would like to go with immunotherapy for this patient, and the rest of it I would just do some environmental control for cockroach and also environmental control for dust mite anyway, and that is what I would do for this patient. And I also would like to look at the protease content, and I know dust mite and pollens are perfectly compatible because both are low protease. I can mix those two. Then I look at what is the therapeutic dose for dust mite, and you have these different columns there. Allergen extract, major allergen, effective dose, less effective dose, which means it is effective even at a low dose. And the effective dose, definitely it is effective, we know that for sure. So you can choose a dose anywhere in between. So let us empirically choose 10 micrograms for dust mite to be the therapeutic dose. But it is also working even at 3 micrograms if you look at the less effective dose. So if it's socioeconomic, if it is a cost factor, where if to add 10 micrograms it becomes too expensive, you can reduce it. And if it is the other way, you can increase it. So we have a leeway here where I can increase or decrease. You can start low and go high, or you can start high and come low if you want to save money and it's still effective. So empirically, we will say dust mite, it will be 10 micrograms per injection. That will be 20 micrograms per month would be the treatment. Now, Timothy is 15 to 20, so I would go with probably around 20 or around 40. Some people even go 25, so you won't go anything wrong. So let us take 20 micrograms per injection, so it will be 40 per month. And Bermuda is, we'll take a look at it, and Bermuda, the therapeutic dose for all pollens is around 25. So we take 50 of that. So if you look at the concentration where it comes, so we know the dosage, but we will look at the extract concentration. The Timothy grass is coming at the pollens have a lot of antigen in it. 1 cc has about 600 micrograms, except Bermuda has less, about 2 to 300. And dust mite has a lot less. If you look at here, it has got 120 to 160. So I won't go into details of these calculations, which we'll do later on. But basically what I want to deliver is I want to deliver enough of the dust mite, enough of the Timothy grass, enough of the cyanodon. And because of that, I am going to come up with this prescription. And this is a sort of an example how they have done it. But let us go custom make this prescription. And we will say that we will add 1 cc of the dust mite DP, 1 cc of the DF, half a cc of the Timothy, and 1 cc of the cyanodon. Why is Timothy only half? Because I know 1 cc has already got 600 micrograms. I just need 300. That's why I took half. And the rest of it is based upon the concentration. There's only 120. So I am taking 1 cc. So I made up this particular composition for slit prescription. I took 1 cc of the DP, 1 cc of the DF, half a cc of the Timothy, 1 cc of the cyanodon, then made up a subtotal of 3.5 cc. Then I add 50% glycerin diluent. And the reason glycerin is added is it keeps the potency better. It also tastes better for sublingual. I make up a solution, a sublingual treatment set of 30 ml. Now, the dosage I'm going to go through in the next few slides. Usually, the maintenance dose for sublingual immunotherapy it's all empirical, nothing fixed. Nobody has told us this is what you do and this is what you don't do. It's empirical. It's 5 drops per day, every day. And 20 drops will be 1 cc. So in you using 1 cc in 4 days, this will last for about 2 months, that's all. 30 cc of sublingual on this composition will last for only 2 months. No dilutions in sublingual. You start off at the same dosage, no dilution. You start off at the maintenance at the most concentrated concentration level, start away at this most concentrated level itself, no dilution with sublingual. But subcutaneous is different. Same amount you use 1 cc of DP, 1 cc of DF, half a cc of Timothy, 1 cc of Synonon, and here you use only 6.5 cc's of saline to bring up to 10 cc because the dosage on it is only half a cc every 2 weeks. It will last for 10 months. The same amount of antigen here using here for 10 months, there you are using it in 2 months. That means you are giving 5 times more antigen in sublingual immunotherapy compared to subcutaneous immunotherapy. It is not uncommon in the US to give 50 times more. And when you use these tablets, you are going to use 50 to 75 times more of the dosage that you use in subcutaneous immunotherapy compared to sublingual. And that is one of the reasons why we are more careful. That is one of the reasons why we give epinephrine even for sublingual, because we are using a huge dosage to compare what you use in India. Here you are using maybe 2 times or 3 times the dosage of sublingual, but there we are used 50, 75 times. And that is one of the reasons why we have to be more careful. So here you are delivering 5 times more antigen. I know this is going a little too fast. You may not totally be able to follow, but we need to go through this in detail later on again. So how do you do subcutaneous immunotherapy buildup? So you have, first thing you do is you have formulated, this is called maintenance vial. This is the most concentrated vial, and we empirically label it as 1 in 10. And from that we dilute it down in dilution of 10 to 1 to 100. That is, we take half a cc of that, use and add 4.5 cc's of saline. So half a cc plus 4.5 saline is 10 times dilution. 1 in 10 becomes 1 in 100. Same thing becomes 1 in 1000. Then again dilution 1 in 10,000. And that's what you do. So you start off with the most dilute, which is vial 1, which is labeled, which is 1 in 10,000 weight per volume, and start with 0.1 cc subcutaneous, the dosage, and then you go ahead and increase to 0.2, 0.3, 0.4, 0.5. This is the allergy injections every 3 days. Then you immediately go to vial 2, same dosage every 3 days, build up, then go to vial 3, build up but once a week. And then vial 4, where you build up to 0.5, sometimes we stop at 0.3, then we repeat it 3 times per week and then go every 2 weeks. So it takes about 24 injections to go up to the maintenance dose in a standard subcutaneous immunotherapy program. So it takes about 4 months to reach a maintenance dosage. Now, sublingual, I will tell you in a minute, and sublingual, the way it is done is there is no build-up. You start off with 1 drop per day under the tongue. For the first week, you use 1 drop per day, every day for first week. Second week, you use 2 drops per day. Third week, you use 3 drops per day. Fourth week, you use 4 drops. Fifth week onwards, you use 5 drops per day. Continue like that. And at 5 drops per day is the maintenance. You continue for the next 1.5 or 2 years. And until things are getting a little more stable and better, and then you might be able to reduce or modify the dose if necessary. Suppose the patient doesn't do well after 2 years, you can reevaluate the patient and you can actually make it more concentrated, add more antigen, less diluent, and that is the only way to work out, because everything is empirical with non-standardized antigens. Now, coming back now to subcutaneous again, here there are different types of schedules. What we call as conventional schedule, which I just went through, where you need about 24 shots, takes about 4 months. Then there is a daily, you can give daily allergy injections and build them up within a few days, and there is a cluster therapy where you can give 2-3 injections in 1 day, and there is also rush or modified ultra rush therapy, we can build them up in 3 days or 2 days. The faster you go, more risk it is. So with rush, modified rush, ultra rush, the chances of having a systemic reaction is significantly high, 30 to 35%, whereas with conventional it could be less than 2%. So for risky situations, why do people want to take this risk? Because there are some people who are very high, especially executives in the industry, who don't want to keep on coming to your office every week. They say, I want to get built up in 3 days this week. Can you build him up, doctor? Can you build me up through to maintenance? We can say, yes, but I need to pre-treat you. We will treat them with antihistamines and steroids. the day before the injection, through the day of the build-up, and the day after. So we continue the steroid course, systemic steroids, as well as antihistamine H1 and H2 for about 4 to 5 days. During those 4 to 5 days, we do this modified or ultra rush and build them up to maintenance. Does it work, and does it work clinically, and does it work immunologically? Answer is yes for both. But what will be the risk with pre-treatment? After pre-treatment, the risk is reduced to what it is with conventional. So it is less than 3% to have any type of systemic reactions. So we did this, we introduced this rush therapy in Bangalore at one of the major institutions, and they were able to do rush therapy for at least 300 to 400 patients and published that study. Dr. Giri Gaud did that, and it was a very well conducted one. So this is something you could do on a selective basis. And the conventional is what we use most of the time and seems to work fine. And the maintenance phase, you can do it every 2 to 4 weeks depending on, but the usual duration of therapy is about 3 to 5 years. And you can get local reactions. Local reactions are fairly common: redness and swelling, which occurs within 15 minutes. And you can also get a delayed swelling, which is due to a different mechanism, comes a couple of hours later. But the question is this a predictor of systemic reactions? If the local reaction is big, do you have to worry that this patient will have a bad systemic reaction? Answer is no. Local reactions are not a predictor of systemic reactions. So you can get systemic reactions with very little systemic reaction, with very little local reactions. So systemic reactions can occur independently of local reactions. So local reactions can be uncomfortable, but may not be dangerous. And systemic reaction is something you need to be very much aware, something you have to be careful. Now again, we are talking about subcutaneous immunotherapy. The major risk factor, as I told you before, is asthma. If somebody has symptomatic asthma, don't give allergy injections or even sublingual immunotherapy. Don't give that, because you are just going to increase the risk of having some problems. Or you need to be careful with somebody with very high allergen sensitivity, high skin reactivity, use of beta blockers. These are all relative type of risk factors, or injection from a new vial, human errors, or injection given during period of allergy symptom exacerbation. Say like somebody has a very high symptom during Parthenium season, July, August, then reduce the dose. Don't keep up at the same dose. And if you are using a next bottle, reduce the dose 2-3 fold and then go up at the same concentration. So you need to do all these different things to keep the program safe and never push too much. Whenever we say half a cc of the maintenance vial is what you reach, there are patients who cannot reach half a cc, they can only reach 0.2. So whatever maximum they can reach is their maintenance. So all these are all empirical doses. Never push it, because pushing it may increase the risk of having a systemic reactions. What is the likelihood of a systemic reaction to immunotherapy? It's a little bit higher in women. The older, the more severe, older, more frequent, and is about 3% I would say. And a lot of these patients, when did this reaction occur? Did it occur during maintenance? Did it occur during build-up? And the answer is occurred in both. It can occur in both when you are even on maintenance, and it occurred even when they were being built up. And local reaction, I repeat, are not a sensitive predictor of future systemic reactions. So we cannot anticipate who will have reaction, who will not have. So it is very important for us to make sure whoever is taking allergy injections to wait for 30 minutes after the injections in front of you should be visible. They can't just disappear. And everybody carries an epinephrine anyway. So systemic reactions have been reported to occur even after 2 hours after these allergy injections. And what is the most common symptom of a systemic reaction is 52% of them will have dermal. First thing they will say is, I feel hot and I don't feel that good. I feel itchy. And some people will say, I feel woozy. I feel I feel sleepy. And children don't complain that much. That is another thing you have to be very careful. Children don't, they just suddenly, they fall to the side and because of hypotension. So all these things have to be watched very closely. And the best way to take care of it is when they start feeling hot, don't wait and start taking vital signs and all that. Give epinephrine. First give epinephrine and then do all your work, and then try to evaluate and see what's happening. Because reactions can move very fast. Within a few seconds they progress, and they can be hypotensive and get into huge situations. And we have taken care of many patients like this. And so important thing is to give epinephrine immediately. And another very important thing is one of your assistants or you have to document everything. If you do not document this episode, there is a future possibility of a significant medical legal issues in these patients, because these patients feel very uncomfortable after a systemic reaction. They think it is your fault, you did it, and they would go to the lawyer and say, I went to the doctor, he caused this, almost I died, that type of stuff. And you could end up with medical legal cases with systemic reactions. So that the only way you can protect yourself is to have documentation to show that you took care of it. And even if you took care of it right and you didn't do documentation, you are not protected. So documentation is very, very important, and documentation should never be altered. It should be in the original writing and you should live it. Even if there's a scratch mark and all that, that's perfectly okay. 17% of these reactions are just to be severe. 32% occurred 30 minutes, 8% occurred after 2 hours, and it can occur quite late also. So you need to be aware of it. Now, can people die of immunotherapy? Yes, can, but very rare. So out of allergy injections which are given in millions, over a period of 40 years, there were 46 fatalities. And that seemed to occur mostly only reason why they died was they were all symptomatic due to asthma. Majority of these people, 76% of fatal reactions were having symptomatic asthma, and 36% had prior systemic reactions. So if somebody has a history of prior systemic reaction, somebody's asthma is not stable, these are all very, very high risk patients. So you have to be very, very careful in these patients. And mixing lab, I can just run through very, very fast. And this is done, this Dr. Mahesh's office where the mixing is being done by Mr. Ravi. And ideally, it should be done in a well-equipped laboratory. Basic sterility precautions need to be taken. It is a prescription which is more crucial. Actual preparation is not crucial. It's a prescription. You need to follow the prescription. And the staff has to be educated. No cell phone, nothing there. He should not be disturbed. And no food supply there, no coffee, water, nothing. And should be left around, no TV. None of those sort of deals, no telephone calls, no cell phones. And all the concentration should be there when has to be towards making up the vaccine, mixing up the vaccine. Otherwise, they are going to make mistakes. And the separate ideally there should be a separate area for it. It should be clean. Doesn't have to be sterile. This procedure is not sterile, but at least you should have some basic things like gloves and head cover, and you don't need a hood for it. And it should be bright, it should be quiet, and ideally there should be some ventilation and no distractions. And what we need is that stock bottle that I mentioned. We make up the 30 cc bottle for sublingual and 10 cc for the subcutaneous. Those are the two things. But we do not do subcutaneous immunotherapy vaccine in the offices. It is always done by the pharma company. 10 cc is the dispensing bottle for sublingual immunotherapy. So 10 cc is a dispensing bottle, 30 cc is the stock bottle. Never try to do any type of subcutaneous immunotherapy preparation mixing in your offices. Is terribly risky, and you will have some major lawsuits. It should be prepared in highly sterile conditions, under very well controlled conditions, and that is done only by a pharma company. But sublingual is different. It is not a very highly sterile procedure. And these are all the different suppliers where you can get all these different supplies from. All these glass vials, 10 cc dropper vial, as well as the rubber caps, sealing caps, and all that. And one thing that Ravi is not doing that, he's not wearing a cap and he's not wearing gloves. So that needs to be corrected. And ventilation is there. And these are all the things that he has got lined up there. And this is what he's sealing. He's capping the bottle. He's filled up the bottle. He's sort of capping it. He has got the dispenser in which he is going to give the 10 cc for administration on a daily basis. This is the one that comes from the factory with the very, very concentrated 30,000 AU, and then he brings down the dilution to 5,000, then makes up this dilution, the treatment program, and then it is sealed and it is ready to go by mail. And the proper documentation is kept, and it is ready to go to the courier. And studies have shown when you send these extracts by courier, even if it is out there for 24 hours, it does not matter. But if it is left in the sunlight for several days, yes, it matters. It also depends upon concentration. Higher the concentration, lesser the disintegration. Lower the concentration, more the disintegration. So if you have dilute solutions, yes, it will disintegrate fast. And these are all certain standardized meter dose dropper pump for sublingual immunotherapy. Instead of drops, which is sort of gross and which is non-standardized, you could use this and you can measure. One puff will deliver 50 microliters, and this or 40 or 25, whatever your dosage could be done. And these are available. Mr. Guru Raj, I think, has all these things. And this is another way of using sublingual immunotherapy. Some people even dilute it. So you could do dilution for sublingual immunotherapy in very highly sensitive patients where it is not just a maintenance vial. You can do vial 1, 2, 3, and based upon that, you could also go ahead and build them up. And I won't go through this completely, and basically telling you that a build-up can happen with sublingual immunotherapy also. Now we move to the last portion, a clinical scenario where it's an 18-year-old male, and he has got chronic nasal congestion of 5-year duration. He has got significant nasal findings. He has positive allergies on the maternal side, which is more important. And your impression and what will be your investigation panel? What will you do? Generally, I have used this for discussion. Because of time issue today, I probably will not do it. Dr. Mahesh has to start taking. So I would like you to use this as your assignment. I would like you to use this problem as your assignment, and please write this. We will give you this thing and use it as an assignment, and we will go through this as an assignment. So please answer all these different questions which are there, because it is covered in the talk, and you need to go and read your literature and also reading materials, the textbook, and then start writing your answers. Write the slit prescription, write the skip prescription, answer all those questions, and then we will send us back and we will go through it. So then these are the answers for it, I think. So let me, few final points. Both are effective, both prevent asthma, both prevent neosensitization, both are effective, but sublingual is slower. And these are comparison, which may, both are effective, but with sublingual, it is safer, but subcutaneous is more inconvenient, but a lot more effective, more systemic reactions. And some of the future therapy I've already gone through before. And omalizumab and adjuvants are being used. Omalizumab definitely used now. And there are all these modified antigens that are being used to reduce the allergenicity, keeping the immunogenicity. And nasal immunotherapy, epicutaneous, intralymphatic are also being used. But I don't have a whole lot of experience with those things. Oral immunotherapy is also now in the vogue selectively for accidental ingestion of foods. And some of these studies have shown prophylactic immunotherapy, that is giving immunotherapy even before the child is born, seems to be effective. So there are certain studies being done where immunotherapy is given to pregnant ladies, and to see whether that will help to reduce the incidence of the allergies in the child that's being born. And also immunotherapy, early immunotherapy, and introduction of these foods early enough in the high-risk patients, that is the LEAP study. That is also a sort of a tolerance build-up, that is skin is sensitizing, GI tract is tolerance, and that is the principle behind it. And to final points is slit is less effective than skit, Slit is safer, but not totally. Slit is effective as a monotherapy. We have not shown that much as a polytherapy. It says no dose response curve, but actually there is. We have demonstrated that there is dose response curve when we use sublingual immunotherapy tablets. And dosing issues definitely persist. We still do not know what is the exact dosage with sublingual immunotherapy. And when you use mixture of antigen, it seems to be very less effective. So if it is used as a single antigen, it is quite effective, not yet approved. We in India, we need some good study. And thank you very much for your patience for this very long talk. And the important thing for you to know is the disease will not wait for you. So do not procrastinate and keep on postponing in treating your patients who are progressing, who have got progressive allergies with allergen immunotherapy. You need to consider it strongly. Thank you.